This is Jose Merino, Editor-in-Chief of the Neurology family of journals. The Neurology podcast provides practical information to neurologists and other clinicians to help them provide better care for their patients. Thanks for listening and have a great week.
Hello, this is Halley Alexander with the Neurology Podcast. Today we're talking about the management of status epilepticus, specifically Pediatric Convulsive status epilepticus, and how seizure action plan and adherence to status epilepticus treatment protocols can affect outcomes. Joining us today is Coral Stredny from Boston Children's Hospital and Harvard Medical School to discuss her work on this topic. So Coral, welcome to the podcast. Thanks for being here today.
Thanks so much for having me.
Now, I want to jump right in. And starting from the perspective of the seizure action plan, how did having a seizure action plan affect outcomes in your study?
So we studied how implementing seizure action plans or a personalized seizure rescue medication treatment algorithm affected patient care. And we found that those patients who implemented the plan received their anti-seizure medications faster, they had shorter seizures, and they were also less likely to be intubated as a result of their prolonged seizure.
Great. And let's maybe actually back up too, because some neurologists and maybe even some adult epilepsy specialists might not be as familiar with seizure action plans. So can you explain what that is?
A seizure action plan is a plan that includes a personalized seizure rescue medication algorithm for use by patients and families, as well as schools or other healthcare providers. For the purposes of this study, we considered any inpatient or outpatient documentation of a rescue medication plan that detailed the medication choice, the timing of when you were to give the medication after how many minutes of seizure, for instance, and the suggested dosing for that medication for at least the first anti-seizure medication to be used to be considered a seizure action plan. Ideally, however, in the real world, I think that seizure action plans should be available for all patients and include more extensive information that can serve as a quick guide to each individual patient and their seizures, including what their seizures look like, how often they happen at baseline, and what to do in a seizure emergency. And a seizure emergency may be one single prolonged seizure or a cluster of seizures or both, depending on each patient. And in addition to medication to be used for a seizure emergency, a seizure action plan should ideally include a guide on basic seizure first aid that could be helpful for non-medical personnel using the plan, such as patients or families at home. I'll also add that in my personal practice, I try to be as clear and descriptive in rescue medication prescriptions and feeds as I can to best equip the family and other providers, such as when should they be giving the first medication, after 5 minutes of seizure activity, or potentially even sooner for some patients who have a frequent history of status epilepticus. And what is a seizure cluster for that patient? How many seizures happen in what time frame, and when should that prompt a medication? I think these details make the emergency treatment plan faster, and they decrease uncertainty in a caregiver's mind in an already quite stressful situation.
So a follow-up question there, if a patient has different seizure types that maybe are treated differently, do you include different action plans for different seizure types?
Yes, in a detailed seizure action plan, you could include different plans for different types of seizures, as well as quite typically we have patients who have a different plan for a seizure cluster. Say they have 2 brief self-resolving seizures in 30 minutes or in 1 hour, where they might get a medication, and that might be different than the medication that they get or receive if they have a single prolonged seizure lasting greater than 5 minutes. And so we can detail all of these variations within a plan.
And so that plan is documented in the medical chart. Do you put it specifically in your note, or is there a different section of your medical charts where the seizure action plan could be found?
So in doing this study, we actually used this to serve as a baseline assessment of our practices at the time when we conducted this in using seizure action plans. And in doing so, we found that many of our action plans at this time, starting in 2015, 2016, were handwritten on paper, and they were variably scanned into the medical record as we didn't have an automated process for this. And so as a result of this, we actually launched a multidisciplinary quality improvement initiative to optimize our seizure action plan structure and to make it electronically available in our medical record in a central location where everyone knows to look, in a way that could also be completely customized to each patient. And as we were doing this, a similar customizable action plan, which we call a disease action plan at our hospital, is also available for other disease states, such as things like anaphylaxis or constipation, as a result of this quality improvement initiative. And this is now our standard of care in our department and in other disease states across our hospital, where all patients with epilepsy or seizures will have a seizure action plan in the seizure action plan section of their medical record.
Excellent. Okay. And then the patient gets a copy of it as well.
Exactly. So it's available to them on the portal, and then it can very easily go to their school as well, so that the nurse at the school has access to the plan as well as the medication order for seizure rescue medication to be used at school, as seizure action plans are now legislatively mandated to be available in schools in many states across the U.S.
Great. And then this study that we're talking about today sounds like it was born out of that quality improvement initiative. So can you tell us a little bit about what you did in this current study?
In this study, we included both inpatient and outpatient documentation of a seizure action plan, which we defined as at least having the first medication named, when to give it, and the suggested dosing. And we looked at how, if you followed this medication algorithm, it affected patient care. And as we discussed, it did improve patient care in a few parameters, including receiving faster medications, having shorter seizures, and a lower likelihood of intubation. And in addition to looking at these personalized algorithms, we also looked at established status epilepticus protocols. And in particular, we looked at our hospital status epilepticus medication protocol at the time, as well as the one published by the American Epilepsy Society. And we looked at medication choice, timing, and dose. And similar to the personal medication algorithms, we found that these patients, if they adhered to the standardized algorithms, also had shorter seizures. They received medication faster, and they were less likely to be intubated. We also found that patients were more likely to be responsive to benzodiazepines, meaning that they didn't need to receive additional non-benzodiazepine medications.
And now let me just ask you quickly, what is the difference between the AES status epilepticus protocol and the one that the Boston Children's version that you use in your hospital?
Great question. They were quite similar. The time to seizure medication and the medication dosing was slightly different between the two protocols.
Okay. And you also found that there was some improvement in the outcomes if the patient had the seizure action plan, even if it wasn't adhered to. Is that correct?
That's correct. And we postulated that this faster treatment, even if they had a seizure action plan, even if not adhered to, might be due to the fact that caregivers and the medical providers caring for these patients with personalized action plans may have been better trained or more familiar with the care of seizure emergencies for that particular patient than those who lacked them, although this is certainly something that deserves further study in a larger cohort.
And was there any relationship to, if they had the seizure action plan, how closely they followed the standard status epilepticus protocols, either the AES or the Boston Children's?
That is a great question, and we did not specifically look at that variable as in those, if they did not follow their personalized algorithm, did they then follow one of the other algorithms, but would certainly be of interest to review.
Now, you did look separately, though, at following the established status epilepticus protocols. How did that affect the outcomes?
So with the established algorithms, we found that patients who followed them were more likely to be responsive to benzodiazepines alone and didn't need additional non-dopamine medication to stop their seizures. And similar to the personalized algorithm, they were more likely to have shorter seizures, receive their medication faster, and were less likely to be intubated if they followed these established algorithms. And to look at common areas of where we deviated from the protocols to understand other areas of improvement, we looked at these causes as well. And we found that the most frequent cause was delayed time to treatment, but also incorrect dosing or order of medications was frequently seen as well as reasons for not adhering to the plan.
And what have you changed in your own clinical practice as a result of these findings?
So as a result of this, I think the biggest success that has had a large impact of not only my practice, but also the department as a whole is the standardization of using our electronic seizure action plan to be available for our patients. It also highlighted for me, and I think others in our department, what is most important to include in these action plans to make them as effective as possible as we can for our patients and their families.
So do you give a seizure action plan for every single patient? I know you talked about it being mandated in schools, but for example, if you have a patient who's been seizure-free for several years and maybe has never had a convulsion or never had status before, do they get a seizure action plan as well?
Yeah, so this is an active area of research and interest in the field to try to understand who needs the seizure rescue medication and for how long should you maintain a rescue medication prescription after your last seizure or after you've weaned off of anti-seizure medication. In my practice, I do equip most of my patients, if they've had a convulsive seizure, with a seizure rescue medication, and I typically continue it for at least 2 years or so after their last seizure or after weaning off of anti-seizure medication. But this is certainly an area where we need more research and guidelines on best practices.
Excellent. So just to summarize our discussion so far, having a personalized seizure action plan, even if it was not adhered to, improved time to first anti-seizure medication treatment, experienced a median time to first anti-seizure medication of 6 minutes compared to those without a personalized seizure action plan, which had a longer median to time to first anti-seizure medication of 15 minutes. And as we know, time is very important when we're treating convulsive status. And then you also noted that participants who adhered to standard treatment protocols, whether it was the AES protocol or the Boston Children's, were more likely to be benzodiazepine responsive and less likely to be intubated. And also that most patients should have a seizure action plan, really whether pediatric or adult, because it improves outcomes and it's also mandated for schools. And that you've seen, at least in your center, that having it in a central location in the EHR and also having it available to patients has really helped treatment timing and treatment outcomes at your facility.
And I will just note that at the time that we did this study, we did not have the electronic and centrally available seizure action plan. That was all as a result of a quality improvement initiative that was being done as a result of some of these findings at the time.
Okay, excellent. But it does sound like, to your point, that the improvement is in care timing really is that the patients and their caregivers just having the action plan has it at the forefront of their mind. And then also if they're EMS involved, et cetera, they're already thinking about it because it exists. And so when they arrive at the hospital, it sounds like the thought is that they're getting quicker treatment because it's at the forefront of their minds. They know they have a plan. Even if they make a mistake in following it, it's something that they've discussed with you and that everyone's thought about and that is like ready to go when they get to the hospital. Does that sound accurate?
Exactly. That's our hope. And I think that future studies could look at whether these personalized action plans as well as standardized treatment algorithms improve outcome metrics and additional metrics in a larger population, as this was a cohort of about 60 children at one center. And it would also, I think, be very helpful to compare the effectiveness of the standardized protocols versus the personalized algorithm. Is there a subset of patients that will even more so benefit from personalized treatment compared to the effectiveness of these standardized algorithms that we know work as well?
Yeah, and can I ask a follow-up question there? If a patient has a really well-documented personalized seizure action plan in the chart, but it's potentially different than the hospital protocol, or the standard AES protocol? Is priority supposed to be given to the personalized seizure action plan, or how does that work?
Yes, we would give priority to the personalized seizure action plan. Many times we're giving the first medication that is to be given in an episode of status epilepticus. And oftentimes it is hopefully the only medication that they may need, which is typically a type of a benzodiazepine. But in some of our patients, they may have more extensive plans that are documented, particularly those who may have a history of multiple episodes of status. A certain benzodiazepine has been more effective than others, or they experienced side effects to one benzodiazepine but not another, so that we could customize that within their plan. And if we have a choice for second-line non-benzodiazepine treatment in that patient based on a combination of patient-specific factors, we might also detail that in more of the longer or extensive plans.
Very good. Okay, thanks so much, Coral. This has been really helpful.
Great. Thank you so much for having me.
You can find the article, which is titled Assessment of Seizure Action Plans in Pediatric Convulsive Status Epilepticus. That's available in the April issue of Neurology Clinical Practice or online at neurology.org.
This is Stacey Clardy, your podcast editor. If you've enjoyed the podcast, please take a few moments to subscribe, rate, and review the Neurology Podcast through Apple Podcasts, Google Podcasts, Spotify, or wherever you listen. And remember, you can always head to neurology.org/podcast for our full list of past episodes. Or you can also search by keyword in your podcast app for any neurology-specific topics you want to learn about.